Thank you so much for joining us today during our final week of the American College of Surgeons Wellbeing Month. We hope it's well-being years, decades, hours, minutes. This is an endeavor on the part of the American College of Surgeons to help provide the stories and the tools that we all need to flourish in our career, not just get through it. During the last 3 weeks, we've had some other recordings. We hope you get a chance to see them. But today I'm delighted to just have a conversation with Dr. Susan Mackinnon, who is a professor of surgery at Washington University in St. Louis. She has come up with a really remarkable idea for how we center an OR team into the why we do what we do, that also helps with some issues of professionalism. So welcome, Dr. Mackinnon, and I'm so glad to have this opportunity to talk to you today.
Well, I'm just thrilled to be here today, Dr. Brandt as well. And please call me Susan. I'm sure we'll be on first name basis pretty quick. We're both, I know from a little bit of chatting we did before this recording, we're both really on the same page of understanding the power of positive energy for all of us as we serve our patients.
Exactly. So you said on the same page, and I want to start off with, so I got the chance of reading the paper that you're going to publish about this. And one of the things you mentioned is that this comes out of something else you did, which was the whiteboard technique. And I thought that was great. It's also a great educational tool, by the way, as a way to get people technically on the same page. I have done that for myself, but also as an educational thing. When I have super complicated cases, I'll write that down to make sure that on the whiteboard, so everyone in the room knows where we are. But do you want to just tell us a little bit about that physical, putting an operation on the whiteboard to be on the same page? And then we'll talk about how we move more culturally to be on the same page with your professional timeout.
I love that you've asked that question, because I think that the PTO in part, I mean, surely the professional timeout must have come from seeing unprofessional behavior. So it was something that was missing in the timeout. But before the timeout, before the PTO, we had the whiteboard, and we've used it. I've used it for so many years. I really can't remember where I got that idea from. I honestly can't. But I asked if I could have 2 whiteboards. We operate in room E and F and back and forth. And I wanted a whiteboard, and it's 4 by 5 feet whiteboard. It's got colored markers, and it took a while, but they nailed the whiteboard up for me in both of the rooms that I operate on. Our plastics is either in the E or in the F. So whatever room I'm assigned, I have my whiteboard. And the whiteboard now has 4 parts to it. On the right, on the left-hand side is the upper left-hand side is the patient's story. And it's de-identified by name only. Everything else is exact. And the lowest person on the hierarchy, medical student, intern, junior resident, will write that story. And that is to include the medical students or juniors in the case. So we have very much the key things. I always want to know BMI. If I'm struggling to operate, or we're struggling to operate, I want to be able to say, oh, it's the BMI, it's not me or the instruments. So the BMI is normal, then it must be the instruments. And if the instrument's okay, then darn it, I have to own this. But the key parts, and for me, it's the electrodiagnostic components, health issues. Then on the bottom of that right-hand side column, and the senior resident does this, there's a square, and it's a list of things to our scrub techs of what we're going to ask for that may not be what they think we're going to ask for. So if we need a particular, say I need blue and yellow vessel loops, that sounds pretty picky. So maybe I won't mention that. But and what we're going to use, 1 pain pump, 2 pain pumps, 1 drain, 2 drains, a nerve stimulator, no nerve stimulator, to seal, nerve allograft, whatever, all of the odd little things, the length of an allograft, I'm going to use allograft, all of those. I have no financial disclosure in any product at all, not even the scissors that I invented. So just FYI when I'm mentioning some of these things. So that goes on then that is for the scrub nurse to look at. And then on the left, the upper for most of the right-hand side, it's the steps of the operation. And the first assist is going to be the most senior fellow or resident is in charge of writing the steps of the operation. I've developed 150 surgical videos on operations that I have invented, and they all include step by step by step by step. So they go to these videos, they can see the videos, they know what steps they are. And then at the very bottom, which we've just added in the last year and a half, is a box and it says reflection. And the reflection is what we do at the end of the case, or even during the case sometime, like, oh, why didn't I think of this? Why didn't did anybody assess the FDS to the small finger? Because I didn't. Why didn't I do that? And in the reflection period at the end, my reflection of what I could have done better, which I share with the residents or fellows, is not the same as what the medical student would reflect on. It's not the same with what the fellow or the CN. It's fun to see how we do that. We go in and out of the same operation, and we have takeaway messages about what we would reflect along to do better the next time. And I love that part because, practice and performance is how you become excellent. And we don't get a lot of practice we don't get a lot of practice. We go to the cadaver lab, but it's expensive to go to the cadaver lab. So this reflection really allows us to, in a safe space, reflect on how we could have done it better. You don't want to go to a patient, well, I didn't do it so well today, I'll try better next time on the next patient. That just doesn't work, but the reflection really helps us. So that is the whiteboard. And I'll tell you, the anesthesia group and the nursing group, especially the scrub who's sometimes sitting there waiting, was anybody ever going to start this case? They go through that whole thing. And then my job is to take a different colored marker, go over to the whiteboard and do something, so that they see that I am watching what they're doing. And I'll say A+, sometimes I'll say C-. That's sort of a joke, but only when we're safe with that. I circle things, I move the steps around if they need to be. And then when they get it right, then I say, okay, you can just give me like mini breakdowns on the steps. You've got that. But I love it. And I know the people in the room love it. And part of moving to the PTO was just a more, that's all patient centric, the whiteboard. This is just a simple, it's like, before we started this, you allowed me to do a centering, and I did a centering to try to figure out who I'm talking to. And I decided I'm talking to the medical students. I'm giving them my experience during this discussion in a way that really is a message from me to the medical students now as to what a great opportunity they have to set a different culture environment for themselves. So they'll be not only safe, but comfortable.
So if I can, so to summarize, and the whiteboard, and I think what a great educational tool, right? Everybody before the operation. So if I understood right, you have the medical student do the patient history and story. You have the junior resident, or do what's needed in the operation, and the senior resident do the steps of the operation. Then you leave a space to say, what could we have done better?
Yes, that's it. You summarized that better than I took so long to summarize.
No, that's quite all right. And so you're very passionate about it, which I love. And by the way, I'm going to totally steal this. And even though this is a wellness thing, I guarantee you almost every surgeon watching this who teaches is going to be having this. Can I get a whiteboard in my own?
Whiteboard. And you know what, the whiteboard is with the colored markers, I think is better than somebody prints it out the night before and sticks it on a screen.
Oh,
and it's big. And so I see people looking across the drapes from anesthesia at it. I see the scrubs looking at it. So and I look at it.
So the other thing that's doing, though, and you said putting everyone on the same page, but you also are setting an expectation in the room that everyone there is part of this team, that they need to know that information. And so that's a nice little segue into how this evolved, the professional timeout. I think, and we were chatting a little bit earlier, when we talk about lack of professional behavior in the operating room, for me, there's kind of two big buckets I put that in. I truly believe no one comes to work to do a bad job. And I think most people who are behaving badly would like to be told that in a way that they can see it, understand it, and make changes. So that's my assumption going in. I do think there's a small percentage of people that, whether it's a personality disorder or some other deep bad wiring, are maybe a little different category. So that's one big concept I want to get out there. The other, and I think this, to talk to medical students and residents, is there are behaviors in an operating room that are simply not tolerated. They are zero tolerance. Hitting somebody, cussing at someone, sexual innuendos, racist comments, comments about someone being gay, those are zero tolerance. And so part of what we have to develop is the courage in our systems to report those. So we might want to talk about that. But to me, your professional timeout is the next step after the whiteboard, which is we are setting a culture, and we're going to say it out loud that we're setting a culture, that we're here for the patient. So why don't we start with describe the professional timeout and how it actually happens? So Susan, let's pretend I'm your new resident that has shown up first day, and you're going to explain to me what the PTO is and give me an example.
Okay, well, here we are imagining, close your eyes, almost imagine you're in the operating room, the patient's asleep, the patient's prepped and draped, we're doing our last debrief. Shall we do our last debrief? Yes, we do it. Okay, now, may I do the PTO for you? We're here this morning for Mr. John Doe, and we're here to help him with his brachial plexus injury. And we're, all of our attention is really going to be on him. As well, we've all come here, we're here early in the morning. Goodness gracious knows all the different things that have happened in your life just to get here. And we want to remember that we're going to treat each other professionally as well. By contrast, we are humans, and from time to time, we will knowingly or unknowingly drop below our level of professionalism. And if it's safe with respect to our patient being our highest priority, let's see if we are comfortable enough to call each other out in the moment. If it's not an appropriate time, to call each other out and discuss it later. And if we're uncomfortable going face to face, then get one of our team members, but let's try to keep it all within room E and not go to room F. Do we agree on that? We agree. Okay, let's introduce ourselves then by first name. I'm Susan Surgeon, and then John Scrub, and then we go around the circle and just introduce ourselves by first name. If someone later in the day comes in that is new, subbing in, I will say, Mary, do you know the other people in this room? Or I'll say, I'm sorry, I don't think we've met before. No, we haven't, Dr. Mackinnon. I've come over from South to help you out. My name's Rayanne, and I'll be giving Mary lunch. Rayanne, do you know the people here? No, I don't. I've never met them. And I said, well, this is, and we go quickly through our name again. Oh, thank you very much. Let's go. So that I timed that. Doesn't take much long to do that.
I think that's great. I came to the same conclusion, but a very different method of doing this. But I think maybe it's important for all the surgeons here to say, well, this is not actually a script, it's an intention, right?
An intention, yes. And take it however, I say, do it however you want, but set a moment in your operating room for not just the patient, but for all of us.
Yeah, and I'll probably expand mine after talking to you, but I realized a long time ago the same thing, which is you just need a moment to come back to why you're there. And I read about, I can't even remember where it was, years ago, someone who actually spent a centering time before. And I thought, well, that's probably a little too foo-foo for most operating rooms, but what could I do that would basically give that bigger context? So two things I've done. One is that we get to the end of our regular timeout, and then the last sentence in my timeout is, we're all blessed to be here. And then, I'll joke sometimes, it's summer, I'll say we could be on the roof, repairing roofs in the summer in the South, but we're actually here saving this kid's life, so I'll do something that just kind of pulls it in, but it's very, very brief. Only if I forget to do it now, the nurses or somebody else will do it because it's just become part of it.
And because they want it, I think they like it. They count on that.
I think so too. The second thing is I sort of have come up with 3 rules that I will repeat periodically, but not in an organized fashion like you're doing. And my 3 rules, the only 3 things you have to know to be a great surgeon, is do what's right for the patient. Rule 2 is look cool doing it. And rule 3 is don't hurt anything that has a name. So I tend to use humor more as a way to introduce things. And so I think those rules, which especially look cool doing it, always brings a smile, but that's about professionalism. That's about not being mean or demeaning.
You know, you mentioned the centering, and in my OR, I use a particular prep that needs to dry. So we're all seated, the Bobby's organized, the lights are organized, we're waiting for this to dry. And I will say, let's just, if you would like to join me, I'm going to center myself now with some breathing. And I'm just going to, while we're waiting for this to dry, I'm going to close my eyes. You can join me or not, but this is what I'm doing. And I'm going to slow my breath down. And I'm going to inhale slow and then exhale slow. And I'm going to do 5 breaths to get myself centered so I can really focus deeply on this procedure.
I think that's a great thing to do.
And thank you. That was only like, 5 slow breaths. And I will have people at they're the lower end of the ladder. And they'll say, Dr. Mackinnon, can I do that breathing? Can we do the breathing? They love slow breathing. And what it does is, if I could just diverge here, the inhale is the sympathetic nervous system, fight or flight. Holding your breath and exhaling and holding is the parasympathetic, relax and slow down. Then you inhale, and then you have this slow exhale, and you're shifting from the go, go, go. At 7:30 in the morning, if we're not in the room within a short period of time of 7:30, we get emails, explain yourself. In fact, I got an email and it goes to anesthesia, nursing, and surgery. So I got an email on that. And the reason that we were delayed was because Dr. Mackinnon was praying with her patient. And I had a very anxious patient that day. So we held hands and then just muttered away whatever we mutter away when we're trying to basically center ourselves again. So that breathing, it's easy for me to bring in 5 breaths. And I have a lot of people that like that slow 5 breath. And then off we go.
Let's go for a minute to some stories. And Susan, give us an example in the operating room of someone who unwittingly stumbles into something that's less than kind, less than professional.
Okay, well, I can just tell you about last week. So I think we're having a great day. Everything's going wonderfully well. And there is a new nurse who's only been with our group for 6 months. And she comes up to me later in the day and she's crying. And I said, Mary, what's wrong? And she said, Joan, the hand fellow, really upset me. And I said, when did that happen? I've been with you all morning. And she said, no, we were getting the patient off the stretcher onto the table and you were out of the room going to see the family. And she hit me with the table, the OR table. And I said, she hit you with the OR table? And she said, yes. She said, let's move the table. We turned the table around. And, I've only been here for 6 months and I was trying to do it. And she took the table out of my hand as I was trying to do it. And she jammed it into my thigh. And I'm trying to do the best job I can. And she made me feel terrible. So how I handled that was, I said, okay, well, Mary, I'll look into it. And I went and talked to Joan, the hand fellow. These are not their names. But this is a true story. And I said, Joan, you took the table and you jammed it into Mary's thigh. And she said, what are you talking about? I don't remember anything about that at all. And I said, well, you were something about Well, as we turned the table, when we're getting ready to put the handboard out, she said, oh yeah, well, she didn't know. She's new. She didn't know what she's doing. So I thought I would help her. So I just moved the table. I did not know. Oh my gosh, Dr. Mackinnon, I feel so terribly. I did not know. I did not know. I am so terrible. So at the end of the day, the hand fellow and I are in a small room together with Mary, the nurse, and the head nurse together. And we're in a small room and we talk about it. And Mary, the new nurse, is crying. And then my hand fellow is crying. And for the men in the audience, means nothing when women cry. That's a good thing to know. That's a good message to know. Anything off of sort of boring, you'll cry. So anyway, we just discuss it, and they're best friends. And now Mary runs the they're best friends, everything sorted out. So we got, and I did that myself. I called myself out on a PTO just a couple of weeks ago. I said something, it was not intentional at all, but as it was flying out of my mouth into my scrub's ears, who I've worked with forever, and I adore her, and vice versa. I looked at her and I thought, whoa, that did not go over well. So at the end of the day, I asked her if she would meet with me. And there was a medical student actually who has a degree in divinity who watched this interaction. And I said, I would like this medical student to come and watch me try to apologize. And then the head nurse. And so the four of us met in a little room at the end of the day, and I apologized, and she accepted my apology. And so that's how I work it out.
I have a little different thing when I spot it. And again, I want to point out that the important part here is that the person at the top of the food chain is modeling this. Okay. And everyone's going to have different styles. And I suspect I would be very reluctant to have meetings with groups of people at the end of the day. I tend to handle it at the time and just say, you know what, that came out completely wrong. I'm really sorry. And just move on to the next thing. And then if it's apparent that there's still a little friction, I might say something afterwards and say, hey, do we need to talk about this? And I suspect a lot of people will just have to work with their own way of dealing with this. And again, it's about the intention. You want to set an environment where people are able to apologize and recognize that kind of behavior is not appropriate.
I used the PTO with my offensive behavior, and I looked across when I saw her energy going down, and I said, I want to apologize to you. Can I do it now, or do you want me to do it later? And she said later.
Fine, perfect, even better.
Yeah. So along the line of the PTO, and what you've been saying, Mary, is that surgeons, for heaven's sakes, we're looking after our patients, and we make it us. I mean, it's all about us with our patient. And there isn't an operation I do that I learned as a resident or fellow. I mean, we look after our patients in a very, very special way. And so when I'm introducing this PTO, it's not so that you do it the way I do it. It's so, as you said, you just make it your own, and you always are setting a situation where I want my room not only to be safe for patient safety, I want it to be comfortable for people to feel comfortable so they can be their best self. And my next thing is I would like them to find some joy in this profession that we are so blessed to work so hard at. So the first PTO is just be safe. Just don't hit each other. Don't throw things. Don't tap your foot. Don't do eye rolls. Don't push somebody. Don't be rude to someone. That's just basic safe. I'm trying now with this idea of concentrating on micro and macro aggressions and trying to call ourselves to a higher level so people are comfortable. But my real goal is so they just can find joy and love what they're doing. And that, because how you treat yourself is how you treat others. How you treat yourself is how you treat your patients. And patients need more from us than just our technical abilities.
Well said. That was fantastic. So everyone listening to this, so first of all, if you are an attending surgeon, or you are the top of the heap, if you're a chief resident taking a junior resident through a case or whatever, this is your responsibility. And the message we're sending is, you don't have to use the script. You don't have to use what I say, what Dr. Mackinnon says, but you need to have something that's comfortable for you at the beginning of the case to say, hey, we've got this really technical thing we're doing. We're learning We're all here to do the safe thing, and we're here to have fun. I'm going to actually say that because there is nothing more fantastic than operating on a patient and making them better. So how do you orient your operating room to say, we're doing this together, we're a team? And I just want to remind everybody that let's be kind. So whatever words, however you do that, if it's humor, if it's, a pause in your timeout, just commit to doing that. Now, let's back up one moment and say, what if you are junior in the hierarchy in the operating room and this is not being done? Is there any way you can suggest for people that are not at the top, other than saying, hey, I heard this great video and this great idea about a professional timeout? Is there something to do at the moment or after the moment when this kind of behavior and this kind of intensity is happening in an operating room that's just not comfortable for the junior people?
You're asking me that question, and I'll tell you, I think that I would answer it by saying what you said. The culture sets the tone, and the person at the top sets the tone. And the hierarchy is so important for patient care. When you're in the ER and you don't know what you're doing, you need to know who to call. You need that for patient safety. You have to have a hierarchy. But the way to innovate and find joy is in a flat team where you have a team and everyone, I was saying to my husband the other day when we were talking about this, which we talk about all the time, I don't know how to turn the Bobby on. And I'm not going to be able to operate if I don't know how to turn it on and plug it in. I'm good at saying the Bobby's not working, but I don't know how to turn it on. I know what I do. And I do know that without the nurses filling in all this and that and handing me this and that, I don't know how to clean and keep sterile instruments going. I don't know how to wash the floors to the level where it has to be cleaned up. So it comes from the top. Yeah.
So we're sort of getting to the end of some time here, and any last thoughts, Dr. Mackinnon?
Do you know, I have every several years, I get a little transition in my life where it's like I can sense that there's things happening to me, and usually they're not good things. They're usually very disruptive, but I know and trust that they're there for a meaning in my path. And the mantra that I'm living by for the last couple of years is find joy, be kind, do good, reject mean. So I would finish with that. Find joy, be kind, do good, reject mean. Look for joyful people. That's what we do is do good. We're good at that. And every day, hope that people think you've been kind to them. And the mean part that you were talking about, just detach from that. There's nothing much good coming from that. So go back to searching to be the best person that you can be every day.
That's wonderful words to end on. I want to thank Dr. Mackinnon and thank Jenny and Kathleen who've been helping us with this recording. Dr. Patricia Turner for her amazing leadership in wellness and in every other aspect of not just practicing surgery, but being a surgeon. So thank you all. Please feel free to reach out to either of us if you have any questions, and we'll look forward to seeing you in person, we hope, soon.